Firstly, what we are talking about today is something new, something which we've been looking for quite a while. On one side, we are pushing PAMIs extensively for anybody who has acute infarct, and at the same time, we know what are the kind of limitations we have when we are addressing such a complex situation. So on this background, let me summarize the data that we have for MGuard in clinical setting of STEMI. We all know that MGuard is a mesh-based protection device on a stent platform. It's an ultra-thin polymer mesh sleeve wrapped on a stent. The micromesh sleeve is designed for maximal flexibility without compromising the strength of the fiber. The sleeve expands seamlessly when the stent is deployed without affecting the structural integrity of the stent. I think we'll see a little bit more, but as you can make out, these are the stent struts, and joining them or interlacing these are the mesh that is created. So the MGuard stent was initially used for the saphenous vein graft, and this was actually a physician's demand that we should be using this for acute infarct situation, because it had a great intensity to hold back the thrombus or the debris when you deploy. So initially we have the FIM studies in saphenous vein graft, and in Poland, Dr. Dudek did the STEMI in 60 patients. So not only he followed the TIMI flow, which was obvious as you end up the procedure, but what was also looked at was the ST elevations, the blood score, and of course the 6 months clinical follow-up. And simultaneously, we have other studies going on, enrollment is going on. Some of them are multinational, global kind of representation. In IMOS, you have observational registry, follow-up of 12 months. And in Masters RCT, actually this is a true randomization, the MGuard on one side and the way you treat it today on the other side, including DAS, BMS, aspiration, and so on. In Dudek's study from Poland, what is striking is everything is zero. At the end of 6 months, there were no events at all. So no MACE at any stage during follow-up, including the in-hospital MACE. So this was quite striking. And what is also important is the use of thrombus aspiration was only in about 18% of cases. There was no reflow phenomenon in any of these cases, and distal embolization was seen only in 3% cases. So overall, the way we treat STEMI was totally changed by use of MGuard. There are other studies, one from Italy, 5 centers, 2 years follow-up of 100 cases. The other one from London Chest, 51 cases followed for a year. And the other one coming from Hungary this is the IMOS registry. And all these are actually looking at the MGuard stent. So not only we talk of good acute results, but look at the TVR. The TVR also at the end of 6 months was just around 4%, inside 4%. So this is also a very important feature, that not only you would have good acute results, but you will also have good long-term results. Now this is actually a MGuard comparison with TAPAS. This is not one-to-one kind of comparison, but we all know that the TIMI-3 flow achievement in TAPAS was around 85%, while the one in London Chest was actually 100%. So clearly the achievement of TIMI-3 flow was superior in MGuard compared to the way we do it today. What about ST segment resolution? We all believe that ST segment resolution truly tells us that the microcirculation along with the main circulation is also open. And you can see that the achievements with MGuard are clearly superior to those who were seen in tapas, both tapas with conventional PCI and tapas with thrombectomy. So both these failed to match the results that were achieved with MGuard. What about the perfusion studies? When you put perfusion studies, the blush score is clearly better with MGuard compared to BMS and aspiration here and BMS alone here. The TIMI-3 flow, no surprise, it is seen pretty good in all three. However, it was still very good in MGuard compared to the other two. The ST segment resolution, again, very striking in MGuard compared to the other studies. So on and all, it is suggesting that we have very good results in microcirculation with MGuard. So this is actually a comparison of MGuard results with DES and BMS. And in compared to BMS, we have almost 70% reduction. In compared to DES, we have almost 43% reduction. So we have reasons to believe that you would achieve not only just TIMI-3 flow, but a good microcirculation patency and also a good long-term results. Now, this actually has led to the ESC guidelines to include the mesh-based protection may be considered for PCI of highly thrombotic or SVG lesions. So SVG lesions, STEMI, as well as any kind of ACS where you really believe that there is a huge thrombus burden which might distally embolize and create problems during PCI. So we have reasons to believe that anything related to thrombus, we have something to rely on, something to go by so that we do not embolize distally.